Welcome to another episode of Roll Call, TTSH Nursing's very own podcast, brought to you by TTSH Nursing Organisation Development. I'm Kim.
And I'm Becky, and we're your hosts for this episode.
So according to the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening or incurable illnesses. It hopes to prevent and relieve suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual.
So on today's episode of Roll Call, we have someone with a strong advocate of humanistic care and inclusion of palliative care approach, not just in palliative medicine, but in all other disciplines as well. So please join us in welcoming our advanced practice nurse, Sister Fionna. Hi.
Okay, so actually we recently had a musical for our Nan Tak Seng Hospital's 180th Founders Day, and one of the characters was actually based off Sister Fionna. So the nurse in the musical was called Nurse Felicia, and she was a nurse handling a patient who, was passing away on the last phase of his life and was struggling to come to terms with the estranged relationship that he had with his family members. So it was a very, very emotional scene. I think literally almost every single rehearsal and even on stage on the day itself, right? Like I was crying, and, Nurse Felicia was serenading the patient one of his favorite songs. So was this actually based off a real experience that you had?
Yes, actually, these are all real life cases and stories that we got interviewed for the play. Yes, so whatever you see on stage is true.
Well, we want to ask you something that could potentially be considered as a controversial statement, is whether palliative medicine is one of the, if not the most misunderstood disciplines out there.
Oh, definitely, like 1000% if it's possible. I mean, there have been studies that revolves around negative stereotypes associated with palliative care, because people often think that once I accept palliative care, it means giving up fighting the own diseases. Yeah, so that is the hurdle and barriers. It's well known this is one of the barriers to utilization of palliative care. I mean, you have journals, articles published on that. Yeah.
So what is palliative care to you then?
Like what you defined earlier on, it's actually a holistic care involving taking care of a person with not only life-threatening, but also incurable disease. With the special focus on not just the physical symptoms, but also the emotional, psychosocial, and spiritual aspect of a person and their significant others. Because in palliative care, it's important that we do not just treat the disease, we treat the person. The family members is also an important facet of the patient. Yeah. So we also take them into the consideration while we carry out care for this person. Yeah.
Was there anything in particular that drew you to palliative?
Oh, long story. Tell grandmother story time. Okay, all along I felt that the running joke that I tell my friend is once I can't run codes anymore because I was from the ICU for many, many years. Once I can't run codes anymore, maybe I'll just go and work in hospice. And this story originates from when I first graduated. I actually started in a general ward. That is my first touch with palliative care team. When I find that this group of doctors and nurses, they are so angelic. Really, you don't see them ever get angry.
Yep.
And they're always so patient. Bedside manners is excellent, and they spend quality time with patients and family members. Yep. I think deep down, all of our hearts, right? We also want to spend that quality time, but the reality is that we can't. Yeah, so that was why I always told my friend, I cannot run codes anymore, right? I'll go and work in a hospice. So fast forward many years later, there was this chance that came knocking for me to consider pursuing palliative care in ICU. That basically married the both favorite part of mine, because I love the fast-paced adrenaline feeling in ICU, but at the same time, I think much focus is needed on the dying process. Because the truth is not all our patients survive active resuscitation. And the repercussion that follows can be very drastic to not only the patient, but also the family members. And I think this is the portion that lack focus on, and much help is needed to develop that portion. Yeah, so that's why when the chance came, I just made the decision to switch.
So what do you actually do as a palliative APN?
So basically my team, we work as a team with a physician, myself and the social worker and some of the therapies when it's appropriate. So what we do is we engage the ICU teams and basically we take care of patient who requires palliative care management in the sense that involve largely for current state is removal or withdrawal of life support, be it ventilator or medications. Yes, and through this, we also support the family members in letting them understand the situation and what are the expectations. Because sometimes when we say status quo or okay, the patient is okay, to us okay means not deteriorating, but a family member might think that okay meaning next week can walk out of the ICU. So that's the part that is often the mismatch is there. So we help to bridge this part.
Okay.
We also help to bridge the care between different disciplines because all of us has got good intention for our patient, but sometimes the perspective might differ.
Yeah.
And it's from so many sources, it can be very confusing. So as PAL care team, we go in to provide a fresh eye perspective. I like to describe it as fresh eye and help to basically coordinate all the care together, including speaking out for the family member and the patient. That's part of the advocacy. Yeah.
That you previously mentioned that you do get involved in the ICU setting as well. So how do you integrate the palliative care into such a aggressive and acute area?
A lot of education is needed, and I find that bedside sharing is actually a better way to do one, show one, because I think we often think that discomfort, pain and suffering to a certain extent is a trade-off to the root of recovery. A little bit of pain is okay. So what I'm trying to do is to educate and spread the awareness of even if the person is not receiving PAL care, still for aggressive management, still for time-limited trial of treatment, you can palliate symptoms. Just because we are sick and pursuing treatment doesn't mean we have to suffer in pain or discomfort. Yeah, so there again, it brings down to the balance between how much pain medicine should I give without affecting the blood pressure, without affecting the respiratory center. So all these things needs a lot of sharing, spreading out awareness and education at bedside. Yeah, so see one, do one, teach one. I try. Yeah.
Yeah. And I think that there's always that myth, right? Or I think we were when we decided to interview Sister Fionna, we were saying that how a lot of times, because Becky is in ICU,
Yes.
so a lot of times when nurses see Sister Fionna appear, they'll be like, okay, which one of our patients is gonna what time left? Which one of them is it now? So I think you were saying that it's quite a not what is it an ick? It's quite it's a bit of an annoying stereotype, pet peeve.
This time I must look at the camera. Pet peeves, okay, everybody. Do not say that when you see us or the team, please. We walk into the ICU sometimes and they will look at me, sister, hi. Hey, who is dying? Don't do this, okay? As resilient as the healthcare team are, this is a bit demoralizing. We are not there for people. We are there to make everybody feel comfortable. Okay, patient, family member, and even the team. Because sometimes the team themselves might feel a little bit distressed by the symptoms, by the sense of helplessness because of complex situation. Yeah. So we have to make sure everybody feels at peace. So don't associate me with only dying. That's not nice. Oh, pet peeves, everybody.
Yeah. Are there any other common misconceptions that you feel people have towards palliative medicine?
Oh yes, that we just do nothing but give opioids. Give morphine. Give morphine, give me this. No, not like that. It's illegal. Cannot just anyhow. Yeah. So all this using of medication, potent medication, are done after careful consideration and review of patient's illness and suitability. And these medicines are basically carefully titrated. How fast we titrate depends on the symptoms. So it's not about the speed of increasing the dosage, but how we titrate based on the needs.
Yep.
Yeah, so it's generally very safe even for the very frail and the elderly.
And one thing that you shared with us also was how there's this one misconception that actually no, this is not a misconception, this is the truth. Stopping treatment is also a form of treatment.
Yes. How should I put it? Sometimes it's a bit difficult.
How do you even say? Because how do you tell a family member, actually we feel like we should stop?
A lot of statement, doing less is more.
Yeah.
Because Let me draw an example. Let's say we're talking about somebody who is clearly dying from multiple organ failure, and because of the situation, the condition is not suitable for organ replacement, let's say dialysis. So you can't dialyze, right? But the patient is clearly deteriorating from the building of toxin. So do you still want to actively pursue to buy the one chance, the remote chance of risking further deterioration by dialyzing a patient? So in this case, if all options has been utilized and we think that comfort care measures is the way to go, so this is when doing less is more. So we will explain to the family the situation. Honestly, we often have very, very frank and open conversation with the family member because I think no one wants to intentionally choose a painful option for their loved one. But at the same time, the sense of cannot let go is very real. Letting go is easier said than done. So you need to have the time, the really invest in good time to explain the situation to the patient's family member, to let them understand the options, the pros and cons of various options. And generally, they will choose the less suffering ones. In this sense, where we do less is more, we are not prolonging suffering. Because if you are pursuing active treatment to prolong life, that's different. But when we choose to do less in situation like this, we are not prolonging suffering. You see, so it's two different things that you're pursuing. Yeah, you don't prolong the suffering, you respect the course of nature, and you let nature run its course.
Another misconception, I guess, which is kind of related to that, is how actually PalMed isn't something that people should look at as like a, okay, I think this is more like in the within healthcare professional setting. Like it shouldn't be like maybe the primary team is like, okay, this patient, right, it seems like maybe they don't have a lot of time left. Maybe we should involve PalMedicine. I think one thing that you shared with us was how PalMed can actually be involved way earlier in the care process. What are your thoughts about that?
Like what the WHO definition, right? Once a person is diagnosed with incurable disease, it's not unreasonable to consider PalMed. If you've heard about the illness trajectory, it's often like that. Upon the diagnosis of any incurable disease or life-threatening disease, the portion of treatment will be much higher, little bit on PalMed. But as time goes, this ratio will be inversely proportionate. As time goes, you exhaust your treatment option, that's when PalMed portion should increase gradually, right? But in acute situation like in the ICU, we can go hand in hand together. Right. So again, sometimes I joke, I say, hey, don't call us at the last minute when the person is dying because I need some time to do my work, right? I do not have the luxury of time to build rapport with patient's family, like in a general ward. So really, it's at the identification of a very severe illness that you think reversibility is very low. Involve us. Involve us. We can coexist with active management. So that we know the family know us. It's easier to bridge to comfort care or even a less aggressive management when really the situation warrants. So get us in early, okay?
What is and all are your favorite part of your job?
Favorite part of my job? I think the rapport building, the relationship that I get to build with the patients and their significant others. As cliche as it sounds, you often hear the healthcare team saying that patients and their loved one are our teachers, and we are at a privileged situation to hear about their life story. Example would be case in point, the patient that was in the musical. And who are we? Basically, we are strangers, right? We just come to you and say, hi, I'm your palliative care nurse, and you pour your heart and soul to me. How many of us will do that? But somehow, patients and their family members will tell us all these stories. And I think really you learn a lot. You learn a lot from them. And I think the favorite part will really be when the eventuality comes, when the patient passes on, and the family members is able to thank us with this weak smile, So we are sad, but you are at peace with what happened. So I think that's the most important. Yeah, and sometimes you see them along the road, they will still come and say hi to you. We still end on a peaceful, lighthearted note, the relationship between us and the patient and family members. Yeah, so that's my favorite part.
Then what is the hardest part of the job? Actually, who knows? Actually, your favorite part could be the hardest part as well, you know?
The hardest part, there are two portions, I think. The hardest part would be internally, us trying to explain the situation to our various discipline group, multidisciplinary group, right? Helping, letting them see our perspective. Letting them see that actually pain, the symptoms or the breathlessness is not a trade-off to treatment. That part is a little bit hard because we are not the primary team, so we have to respect boundary. Sometimes a patient can be in a lot of pain and discomfort, but yet they will tell us, because good rapport, right? But they will not dare to tell the primary team physician. This part is a little bit tough for us, but we still try and advocate. I mean, we will advocate for that, but this is one of the challenge internally. With family members and patient, generally is the managing the expectation, because every one of us come with our different mindset. Sometimes they Google fentanyl and then they get frightened by the opioid crisis in the States, right? So we often have to explain and acknowledge that. Or they might Google Dr. MedWeb, usually got a question asked, which we welcome the questioning. We will just correct the information. Or those that because of bad experiences previously that they totally do not want, or because of their own trauma, they feel that we shouldn't pursue palliative care, is not sensible that we starve their loved ones, to continue pouring fluid, and the patient is so breathless already. So these are the part that I find is difficult because there are just some that you can never get across to them. But we take solace in knowing that as long as we tried our best at a given point in time. That's what I always tell everyone. There are some patients that do not have the outcome that we wish to get. Not all deaths are peaceful. That's the truth. But as long as we try our best during that period of time, we should be at peace with what we have done.
So it sounds like you're going through a lot of emotional journey every time you start a new patient. Experience burnout.
I think for myself, how I cope is my ICU training allows me to compartmentalize. So I compartmentalize a lot, right? So I allow myself to feel, to totally be involved with the person or the patient, be it the family member or the patient themselves, because I find detachment is very painful. It's very cold. And if you genuinely care for that person, there's no way you can detach entirely. But for my own sanity and for our own well-being, you have to detach. So if I feel I can have a lot of emotion, a lot of feelings, after work, I try not to think about it. There are some special patients that you will want to know what happened. So these are the situations where the nurses will teams me, sister, FYI, so-and-so is okay. Or so-and-so has passed on. I know you want to know. And it's okay, I really want to know. It's not about bothering me after hours, it's different. Because you know that our journey has ended, the relationship has ended, and that it's a closed chapter. So that part is quite important to me. Sometimes I attend wakes. So we, again, within the PAL community, we joke our locker always has got black dress. Because you never know, right? So, so we attend wake. It's not because we are so but it's closure for ourselves. It's closure for ourselves. And that part is important.
Definitely.
After you compartmentalize your feeling, you have to acknowledge that feeling. Be thankful for the experience shared, like the patient in the musical. So part of acknowledging him as a person is me sharing his story. For him, I didn't attend the wake because it was a long weekend, and I take solace in knowing that the long care journey that he had with us, I gave him nothing less of 100%. We gave him nothing less of 100%. So that part is very important.
Mad respect to all the palliative nurses. Okay, when I first joined nursing, I remember I was like, you know what? I want to be a geriatric / palliative nurse. Because very in touch with the emotional side of nursing. And I was like, okay, then I went into geriatrics and I nursed some palliative patients also. And I couldn't. Like, for me personally, like, I really have a struggle, like, emotionally detaching myself from the situation. So I get very invested. So I always say, like, for geriatry and for palliative nurses, right, I really mad respect because I feel like the emotional tenacity and the mental resilience that you need to have, like, not only, like, to be the best nurse that you possibly can for the patient, but at the same time to protect yourself as well. Like, it's really something that you need to be very intentional with.
You should have a good team with you. A good team helps. So the truth is, right, we are not sane, okay? So there are times we do get angry. Yes, Palmat people do get angry. It's just that we are very good at controlling ourselves, our behavior, our language. So you need to find a safe space. And I think this is across all discipline, regardless where you are, be it you're in the acute side, you are at the step-down area. Because the truth is you are in the business of caring. There will be emotions. Patients, from family members, from even the teams, right? Our fellow healthcare professionals. So you need to acknowledge that feeling you have. You are allowed to have feelings. Ventilate it within a safe environment. Go to your team, people that you know will understand your situation, and ventilate. So last time we often joke, right? I need to go to the prep room for 1 minute. Go in there, take a deep breath. Okay. Come out fresh, look professional, right? Yeah. This is important. I mean, we can joke about it now, but I think this is very important. Yeah, because really you can't go on like that for too long. And you can't pour from an empty cup. So you need to give yourself time to refill again. Yeah, correct.
So last question, how do you think we can better equip the nursing community to adapt a palliative care approach, regardless of the discipline they're in?
Wow, this is work in progress. A lot of work in progress. I think spreading of awareness. Yep. Like I said, all of us choose this profession to help people. I think there's certain level of altruism inside. But I'm not saying that all of us have to be self-sacrificial. No, this is not sustainable, okay? But the awareness to influence the caring culture is very important. All of us are so weighed down by the work, the administrative work, the paperwork, all the charts and things that you need to do, the processes. Although we are in the midst of reviewing all this thing, but the truth is, it is still more than our patient contact time, right? So I think, unfortunately, we have to choose. And how to choose? You prioritize the patient that's the sickest, that needs the most attention that you can possibly give during your shift. So we need to be able to tell our nurses that, this is how you can prioritize and it's necessary. And what are the symptoms that you have to look out for? How to be more mindful so that you acknowledge the patient as a person, not as a disease or bed number. And this is how you deliver a person-centered care, humanistic care, a dignified care. Yeah, and that part is very important for the overall health-seeking journey for the person and their loved ones. Yeah, and that itself is palliative care approach in a very large sense. It's not only about the symptom management.
Sister mentioned just now that, you can't be pouring out of an empty cup. So how can we help those nurses who are experiencing this possible burnout from complicated cases?
One initiative that is up and coming that we hope to do is to have this case discussion, complex case discussion, probably at each level at a regular basis where nurses can bring up complex cases for them to share. It's not like a case study. We want to give them the avenue, the safe environment to talk about this case, how they feel about this case, because sometimes certain clinical decision might be a little bit confusing, or the nurses do not have the opportunity to understand the exact reason behind certain decision. So this actually will inevitably result in moral distress experience. And we all know that if you have accumulated prolonged period of moral distress, this will lead to burnout. So I thought it would be important for them to have an avenue to talk about this case and ask why. Why is this being done? Why is this decision? Why are we doing this? Why didn't we do this? So in hoping to give them this safe environment to talk about it, will reduce the chances of moral distress. And that they will be aware of the situation, be aware of certain decision, and they can go and spread the information, spread the knowledge, and changes practice on the ground.
This wasn't inside our original plan, but I just wanted to ask, right, because of the wealth of knowledge that you just shared with us. So do you have any advice for... I have to end right with the advice question. Do you have any advice for... Okay, because I'm just thinking back and looking back of like when I was in Jerry on like taking care of PAL patients, you know, like, and I didn't know how to handle or I can't compartmentalize as well as you do. Do you have any advice for any nurses who maybe are in this particular specialty, who maybe are struggling a bit? What can they do? You know, maybe on a more personal level.
More personal level. I think before you choose PAL Med this route, you should have enough clinical experience first, because you need to see enough. You have a wide breadth of clinical experience for you to understand why certain things are done, why certain clinical decisions are made. If you are already on this path, right, find your safe environment to ventilate. Talk to people.
Yep.
Talk to people and don't be burned down by compassion fatigue. Because you feel that I have to give my 101% to every single patient. You can't. We are not Superman. Even Superman doesn't do that, I think. You have to be aware of your own limitation and just know that if you have given your best at that given point in time, that's all it matters. The outcome, we can't dictate. We can only be at peace, do whatever you must to the point where you are at peace when you leave work at the end of the day. Yeah, and talk to people. Do not keep quiet about it. That would do.
Nursing, I feel like it's such a heavy job, right? Responsibility. It's not just, we just go to work, change diapers and all that, but there's so many complex things that we have to manage and many different people's expectations that we have to manage also. So I feel like no matter what discipline you're in, finding that safe space and environment to just share experiences, that's what nursing is about. And I feel like that's the kind of support that nurses need to give to each other so that we can tide through this career.
Because we are doing very hard work and we're also doing very hard work. You see. So hard work, you really need to take care of yourself and each other.
And with that, we are done with this episode of Roll Call. Thank you so much, Sister Fionna, for joining us and sharing with us all your experiences and knowledge as well. You can also check out this podcast on Spotify at Nurses of TTSH.
So do give our channel a follow and click the bell to get notification every time we post a new video. Don't forget to give this video some love by clicking the like button and dropping us a comment.
And for more updates and opportunities to contribute to our future episodes, please feel free to follow us on Instagram and TikTok at Nurses of TTSH and DM us if you have any ideas or anyone you would like us to feature or if you would like to come on board as well.
We'll catch you in the next roll call. Have a good shift. Bye-bye.